My name is Simon de Lusignan. I'm a general practitioner and a professor of primary care and clinical informatics. That's all about big data in the Department of Primary Healthcare at the University of Oxford. I'm also the director of the Royal College of GPs Research and Surveillance Centre, also referred to as the RSC. The RSC is a network of spotter practices, or to give its technical name, a sentinel surveillance network that monitors community infections like flu, more recently COVID, and respiratory syncytial virus, RSV, and other viruses. It is part of a wider national sentinel surveillance system run by the UK's Health Security Agency, UKHSA. My research focuses on how we can use routine data better to improve care, can enable new roles in healthcare, and also help patients and the population do better self-care. If I have a catchphrase in what I do, it's coding is caring. This is intended to really encourage my colleagues in general practice to really keep high quality lifelong medical records, because well-coded and curated computerized records help with safety alerts when treatment is required, and enables us to better monitor the safety and effectiveness of a wide range of treatments, in addition to the sentinel surveillance we're involved in. The project I'm going to talk about now is something called the Wellcome Quinquagenarian, QQG project. Quinquagenarian is Latin for 50 years old, and we're creating a QQG biomedical resource. And we're putting together historic data of over 50 years duration to make it easier to conduct research, particularly about these viruses that cause winter pressures and illnesses. These viruses are constantly changing, and as they change, they sometimes cause less, but sometimes more serious disease. We've all experienced how different variants of COVID, for example, the Delta and Omicron variants, resulted in a change in the pattern of illness, and also responded differently to COVID vaccination. The biomedical resource we're creating should advance the way we use health data, clinical informatics, and work with biomedical data to provide new insights. The QQG biomedical resource will build on this fantastic history of the Royal College of General Practitioners Research and Surveillance Centre, the RSC I mentioned earlier. The RCGP created an epidemic research centre back in 1957 and actually started sentinel surveillance in 1967, introducing virology testing primarily for influenza in the 1992-93 winter. What sentinel surveillance is being a sentry. We're on watch for infections, particularly influenza and other winter infections. From 1967 to now, the RSC has published a weekly report of the incidence of 30 monitored conditions, now collected from a network of over 2,000 practices. And its principal use has been the monitoring of influenza and other respiratory illnesses, which all have their own morbidity and mortality and account for winter pressures. The key other group involved in this are UKHSA, and particularly their viral reference laboratory, which since this winter of 92-93 has been collecting viral data and also starting to record the genetic sequence of the virus, so you can accurately measure and monitor how the viral structure changes and if any of those changes are associated with a change in vaccine effectiveness. The big questions that the database will create through this project can address really stem from the three unique components it brings together. So our resource is bringing together a unique set of pseudonymized clinical data from general practice, which can be linked to hospital and death data, virology data from the UKHSA reference laboratory, and the genomic surveillance data from these viruses. This gives us the ability to provide new insights into seasonal respiratory illness, such as influenza, COVID and RSV, and also into why vaccines may become less effective over time. The particular questions I think we would focus on are how can genomic surveillance, which is the name given when you have these three components, help us monitor and predict the evolution of viruses like influenza, RSV that's going to be exposed to vaccines for the first time in these coming years, and COVID. The next big question area is what can these data from over 50 years tell us about the change in the instance, in the new cases of respiratory virus infections as vaccination has been introduced. So for example, we can show that there's vastly more influenza presenting to primary care prior to the vaccination programs. And the third big area I think we can work on is applying the knowledge that can be generated from this resource to improve vaccine effectiveness and potentially other public health interventions to control both the expected and the unexpected respiratory infections in the future. To provide some more information about the QQG project, I won't really reiterate its three components of clinical data, virology and viral genomic sequence data, but to talk more about the initiative and the two primary databases we've created. The first data set we have created spans over 50 years. When the RSC started, there weren't computerized records and there wasn't a way of collecting a lot of data at individual patient level. So counts were done of the monitored conditions by age band. And what we've been able to do is reproduce the way data was collected earlier in the later data, so we can get a longitudinal report around the 30 monitored conditions. And this can be used for studies which can look at how as vaccination was introduced, so incidence fell and impact of the level of disease with winter admissions to hospital and mortality. The second database we've created is an anonymised data with individual level data, which we've decided to start from 2008. We started in 2008 because there have been substantially more data collected from 2008 and sequenced, and the sophistication of the viral genome at that time was much greater than it was later. The bulk of the viral genomic sequences are stored in a repository called GISAID. This is a global initiative on influenza, and this database is publicly accessible, so it'll be possible to find the clinical impact, for example, of influenza, the type of influenza from the virology, and the virology sequence data. By creating this genomic surveillance integrating clinical virology and sequence data, we really should be able to advance our understanding of disease patterns and severity, and also provide much more precise insights about vaccine effectiveness and why. This approach is very much aligned. In the USA, there's a Center for Disease Control, CDC. They similarly stress the importance of genomic surveillance in really understanding how and why preventive programs such as vaccination work. We feel the QQG project should be a game changer because this biomedical resource should be able to provide unique insights into how viral change is associated with different degrees of clinical impact, both clinical impact in terms of disease severity, the need for hospital intensive care admission, as well as mortality. So by integrating genomic data with sentinel surveillance system, we're raising the bar on how healthcare data can be used to monitor and respond to infectious diseases. Not only is this work aligned with what's being done in the CDC in the USA, it is also aligned with World Health Organization recommendations. The WHO's Mosaic framework has emphasized the importance of genomic surveillance as being a cornerstone for epidemiological research and pandemic preparedness. This work and creating this resource aligns us with what WHO is recommending as the right way ahead in how healthcare systems respond to respiratory viruses. Another aspect of the RSC is that we're also involved in serosurveillance. This started in 2020 and involves collecting additional blood samples from people who have routine blood tests. The bank of serology samples is curated by UKHSA and can be used to answer specific questions about population levels of immunity or vaccine waning. It was, for example, pivotal in reporting in the COVID pandemic how vaccines against COVID were waning in the immunosuppressed population. This bank of serology could also form part of our picture of understanding infectious disease and countermeasures. Everything we do is ultimately about patient benefit, and we do anticipate this will translate through for patients' benefit. I think we will get greater insights into severity, vaccine effectiveness, and be able to respond better to epidemics and pandemics in the future. And this in the end, it will result in better use of healthcare resources for the benefit of patients and the population. This research matters, this biomedical resource matters, because it will enable us to gain unique insights, unique contemporary insights from the current volume and coverage that we have, and also this really completely unique historical resource that brings together long-term data from now over 50 years, virology and sequence data. I'm optimistic this will make a contribution to current and future public health and the health protection of the population. Well, I'm delighted to have the opportunity to describe the Wellcome QQG biomedical resource, and thanks for listening to things so far. To me, it's fantastic that we've got over 50 years of clinical data we can link to severe outcomes in hospital, virology reference lab data from UKHSA, genomic sequence data, all brought together in a way that they can uniquely support research, and one hopes this will result in the medium to long term in benefits for patients and the population.